Warm greetings and welcome one and all for today's session, TANUVAS Global Veterinary Oncology Webinar Series 2020, Canine Lymphoma and Update. May I request on behalf of the organizing committee, Dr. S. Balasubramanian, Convener and Organizing Secretary and Director of Clinics, Tamil Nadu Veterinary and Animal Sciences University for the welcome address.
Honorable Vice Chancellor, Tamil Nadu Veterinary and Animal Sciences University, and a renowned veterinary pathologist of the country, Professor Dr. C. Balachandran, internationally acclaimed speakers of today's webinar, Dr. Valeria Martini, DVM Ph.D. from Italy, Dr. Comazzi Stefano, Diplomate, ECVCP, Department of Veterinary Medicine, Milan, Italy, who is also a co-editor-in-chief of the International Journal of Veterinary and Comparative Oncology. Co-organizing secretaries, Dr. K.G. Tirumurugan and Dr. M. Chandrasekhar. Technical coordinator, Dr. Vimal Rajkumar. Moderators, Dr. Nazima, Dr. Aresh Kumar, Dr. Stella Esther. Deans of Constituent Veterinary Colleges, heads of the department, Dr. Krishna Kumar, Head of Gynecology, Dr. Arun Prasad, Head of RVSS, Dr. G. Vijay Kumar, Head of VUPH, Dr. Karthikeyan, Head of Genetics, Dr. Kavita, Head of Clinical Medicine, and other heads from the Madras Veterinary College campus, and participants from India and other countries. Greetings, good morning, and good evening to one and all. Let me give a brief introduction about this webinar. Under the guidance of our Honorable Vice Chancellor, TANUVAS, this directorate has so far organized 4 webinars for the students of constituent veterinary colleges of TANUVAS and 5 global webinars for the benefit of students, faculty, field and practicing veterinarians worldwide. In continuation, this is the 6th global webinar, that is TANUVAS Global Veterinary Oncology Webinar Series 2020, Canine Lymphoma and Update, is being organized 3rd and 4th December by the Project Monitoring Unit, DBT-TANUVAS, CRCN, Directorate of Clinics, TANUVAS, MVC Campus. In this webinar series, we have with us 3 internationally acclaimed speakers, one Dr. Valeria Martini from Italy, Dr. Comazzi Stefano from Italy, and on 4th we have Dr. Corey Saba from USA. Just to give a brief introduction, cancer is one of the common causes of death in dogs, affecting approximately 4 million dogs per year. Veterinary cancer registries provide information on risk factors, geographic and breed differences in the incidence of cancer. Malignant neoplasia in dogs ranges from approximately 381 to 852 per 100,000 dogs. Breeds that are at increased risk of developing lymphoma include Bull Mastiff, Bulldog, Boxer, Bernese Mountain Dog, Scottish Terrier, and others. In general, pet dogs share the same living environment as human and serve as epidemiologic and etiologic sentinels for the changing patterns of cancer development observed in human. Canine cancers are described and classified according to histologic and or clinical staging systems that are used in human cancers. Although cancers in dogs share key features with those of humans, the disease progression is typically much more rapid in dogs. The treatment of cancer in veterinary medicine has co-evolved with the treatment of cancer in people. The first report of chemotherapy used in veterinary medicine was published in 1946, when urethane was used for treating hematopoietic neoplasia in a dog. Histology, biologic behavior, molecular aberrations are similar to canine and human and provide a solid foundation for comparative and translational oncology. As such, studying details of cancer in dogs can provide important information that optimizes clinical drug development and advancements in the care of people and dogs affected by cancer. Considering the increasing incidence of cancer in pet and companion animal population, this specific area was chosen to discuss on the updates in canine lymphoma. I am confident that the deliberations out of this webinar will certainly be highly useful to the veterinary fraternity. Thank you.
Thank you, sir. Now may I request our Honorable Vice Chancellor, Tamil Nadu Veterinary and Animal Sciences University, Professor Dr. C. Balachandran for the inaugural address.
Very good evening from Chennai and greeting from Tamil Nadu Veterinary and Animal Sciences University. My esteemed colleague Dr. Balasubramaniam, Dr. Chandrasekharan, and we have faculty members from other clinical subjects, Dr. Krishna Kumar, Dr. Arun Prasad. We have colleagues from animal genetics breeding and animal biotechnology, Dr. Thirumurugan, and from the Faculty of Medicine and other fronts here, and the distinguished speakers of the day, Dr. Valeria Martini and Dr. Comazzi Stefano, and my dear participants from across the world. And we have overall around 1,474 participants who have registered and are from 45 countries other than India. I'm happy to be associated with this because this Tamil Nadu Veterinary and Animal Sciences University, it is well known for its teaching hospitals. At present, we have 4 veterinary colleges located in this state of Tamil Nadu. And Chennai is the leading one, which has got more than 116 years old. And we have other institutes located in different parts of the state. They are also offering good clinical services to the needy people. And in India, this TANUVAS has been the pioneer and forerunner in advancing veterinary clinical sales skills, and also many skill oriented clinical education is being initiated, and it is continuing. One of such effort is that from the Directorate of Clinics, who has started organizing this type of webinars. Nearly, as they said, around 4 of them have done till February of this, and then they started doing on other things, and all these 4 were organized for the undergraduate students of all of the constituent colleges. But now we are expanding in a different manner, and also it is being conducted by this project monitoring unit under the Department of Biotechnology of Government of India. We have got Canine Research Center functioning in this directorate. So for the first time, they have organized this global veterinary clinical sciences webinar in 2020, starting from anemia and blood transfusion medicine in chronic kidney diseases in canines. And nearly 2,400 participants registered for the same from India and 12 overseas countries. So it has been well introduced that globally the cancer is the second most leading cause of death in humans today. In dogs too, it is taking its toll. And there are many challenging issues for the veterinarians to treat them. So in that process, this attempt is being made. And as the dogs are allowed to live their full life, so we are facing many such conditions in this part also. And as the dogs are experiencing spontaneous diseases, they are generally considered as unique models to study cancer. Many comparative studies are also done. And we also made certain studies and published what is happening in human, especially on the mammary cancer, and that are occurring in the canines. You know, the uniqueness of this, of having a mixed type of tumor, it is also challenging. So in this webinar, they are concentrating on the lymphoma. Again, it is another challenging area for us. And I'm happy that they have taken the right lead. And this is also constituting around 83% of incidents in globally. And now it is now known that a full spectrum of lymphoid malignancies seen in humans also occur in dogs, and both share great similarities in account of their morphological and clinical features. So hence domestic dogs prove as great models to study lymphoma with regard to disease progression and response to chemotherapy. So as I said in the scheme, one of the many schemes are run under this DBT sponsored project. One of them is screening of B and T cell lymphomas in canine and cost-effective chemotherapeutic regimen. So this is operating in the past 2 years, and in that they have encountered around 75 dogs having been diagnosed with the lymphomas during the period, and mainly affecting the middle-aged ones around 5 to 10 years of age. And even though there is no sex predisposition in canines, they have found a slightly higher incidence of canine lymphoma in males than in females. And among the breeds, it was much noted in the nondescript dogs, followed by Labrador retrievers. The procedures that were applied for the canine lymphoma diagnosis and differentiation include fine needle aspiration cytology, radiography, ultrasonography, PCR for antigen receptor rearrangement, that is PAR, histology and immunohistochemistry. The PAR assay is routinely applied in the peripheral blood and also in the fine needle aspirate samples. And among the samples that tested positive for the rearrangement by PAR assay, 96.3% of cases were of T phenotypes and 3.6% cases were of B phenotype. This is also supported by the cytology and histology observation, as I have been told. So majority of the positive cases were classified under stage 3, substage A. There is 78% as per WHO classification system. And these dogs have been treated with University of Wisconsin Madison lymphoma CHOP 25-week protocol. So the computer tomography considered as state of the art is available in our institution and is used to monitor the extent of neoplasm and also to evaluate the post-chemotherapeutic effects. So in view of the above observations and to throw light on various aspects of canine lymphoma, this 2-day global webinar on canine lymphoma and update and the TANUVAS Global Veterinary Oncology Webinar Series 2020 is being organized. by our institution, so that it will be beneficial to our fellow veterinarians and research graduates and veterinary faculty. So now in this webinar, topics like advances in the diagnosis of canine lymphoma, European Canine Lymphoma Network, an overview, and canine lymphoma treatment and management will be dealt. So this is open for veterinary undergraduates, postgraduate students, faculty members, field and practicing veterinarians worldwide to provide practical updates and an opportunity to interact with the international expert. I'm also happy to note that they got the presentation in a hot form that will be supplied as a PDF format once the webinar is over. So really, I congratulate the team behind this program headed by the Director of Clinics, TANUVAS, and extend my heartiest wishes to the eminent research scientists around the globe, because we started in a simple manner about 20 years back doing on, because as you heard, the 5-needle aspirate biopsy is one of the methodology by which we started doing it, and which is different from other type of tumors, as you are aware, where the surgical and options are there. Here we have got the issue. So then afterwards, as we started doing this, we know the importance of immunophenotyping. So then we started doing on that, and later this service is made available in the Department of Veterinary Pathology by immunohistochemistry, the markers on T and B lymphocytes. And now this is much more advanced. They are employing those things. It's a good thing. So we are in progressing, and it should happen in other tumors also. This kind of whether it is a clinical staging and histological grading should be done, and wherever it is required should be supported by necessary immunohistochemical one, which is universally accepted, and also other means. And also I'm happy to see the because it is happening in other parts of the world, the networking on this. This should also happen in our setup in Indian conditions, so that the like-minded people who are doing work on this should come together, so share their materials. So this that is how we started this webinar some year back, so that on imaging technology, you share your experience at least among yourself, and students and faculties are benefited within the institute, and then you extend to other parts of either at national level or international level. Similar way, it should also happen in this lymphoma. Again, it's a challenging one. Hope this will take care of in days to come, and I wish this function a great success, and thank the organizers for giving me this opportunity to speak. Thank you, friends.
Thank you, sir. Now I request Dr. M. Chandrasekhar, Professor, Department of Veterinary Clinical Medicine, Madras Veterinary College, TANUVAS, to introduce our first speaker.
Good evening, everyone. Welcome to this webinar on canine lymphoma and update, hosted by the Directorate of Clinics and the Coordinator Project Monitoring Unit DBT. I am greatly honored to be part of this webinar, wherein we from TANUVAS are interacting with the prestigious University of Milan. In my distinct pleasure to introduce the guest speaker for this webinar. In spite of their busy schedule, they have consented to be part of this webinar and readily accepted to share their knowledge and experience with our fellow veterinarian, vet student, academician, and research scholar throughout the world. The first speaker of this evening is Dr. Valeria Martini, a researcher at the Department of Veterinary Medicine and Public Health, University of Milan, Italy. She is virtually with us to talk on advances in the diagnosis of canine lymphoma. She graduated from the University of Milan and further earned a Ph.D. degree in veterinary animal pathology. Her research interests include myelo and lymphoproliferative disorder of companion animal and diagnostic application of flow cytometry in veterinary medicine. She is the author of more than 40 papers on international journal indexed on Scopus. She is also part of the European Canine Lymphoma Network. The second speaker of the today is Dr. Comazzi Stefano, Associate Professor, Department of Veterinary Pathology, University of Milan, Italy. He'll be talking on European Canine Lymphoma Network and overview, which will help us in establishing Indian Canine Lymphoma Network under TANUVAS. He is the co-editor-in-chief of the International Journal of Veterinary and Comparative Oncology. He has a postdoctoral degree in comparative pathology of domestic and wild animal and a diplomate from degree of European College of Veterinary Clinical Pathology, European Board of Veterinary Specialization. His main research areas include hematological and clinico-pathological aspect of lympho-myeloproliferative disorders in dogs and cats, flow cytometric diagnosis in veterinary diseases, molecular marker discoveries in veterinary oncology, and diagnostic cytology of small animal diseases. His current project on Canine Lymphoma Network, he has nearly 105 publications from his side. And when we hosted this, immediately he is hosted under the European Canine Lymphoma Network. Our flyer, you can see in the Facebook.
Good evening. I want to thank the TANUVAS organization for inviting me and all the participants to this webinar. My talk will be about the diagnosis of canine lymphoma. Your professor has already made an overview of what canine lymphoma is. This is a common neoplastic disorder in dogs and has an increasing annual incidence over the last periods, over the last years. It can have many different clinical presentations, but the most common one is the multicentric disease, where all peripheral lymph nodes are enlarged. In this slide, you can see a picture from a published review of a dog with a larger peripheral lymph node and a vena cava syndrome, which resolved within a few days from the beginning of therapy. So, a diagnosis of lymphoma of a dog and treating the dog is important to improve the quality and the survival of affected dogs. The first step in the diagnosis of canine lymphoma, particularly of multicentric lymphoma, is cytology. On the cytological smear, you can detect a monomorphic population of cells. In dogs, it most commonly is composed of medium to large-sized lymphoid cells with scant bluish cytoplasm and prominent nuclei, such as in this case. With a cytological picture of this type, you can definitely diagnose lymphoma. But in a small subset of cases, cytology is not enough to diagnose lymphoma in the dog, since only small cells with mature lymphocyte appearing can be present. Such in this case, with a cytological appearance of this type, you cannot be sure whether this dog has a small cell lymphoma or a reactive lymph node hyperplasia. So what else can we do? Of course, the gold standard to diagnose a lymphoma in a dog is histopathology. Histopathology has to be performed on a surgically removed lymph node, and the pathologist can assess the distribution of neoplastic cells, whether any residual follicle or germinal center is present, and can diagnose lymphoma and give a definitive subclassification. In this slide, you see the list of the WHO lymphoma subtypes for the dogs, and you see that the most important subdivision is about the phenotype of B cell or T cell lymphoma based on the antigen expressed by the cells. To assess the phenotype on an histopathological section, you need to perform immunohistochemical analysis, and usually one T cell and one B cell markers are tested, and whether the T cell or the B cell marker stains positive, you will have the final diagnosis. Also based on the appearance of the cells and the distribution of the tumor within the lymph node. Actually, what most of the clinicians do when facing with a dog with generalized lymphadenopathy is to require lymph node cytology. This histogram is taken from a published survey among veterinarians, and as you can see, almost all of them recommend or require nodal cytology when approaching a dog with suspect multicentric lymphoma, whereas only few of them, less than 30%, recommend nodal histopathology, and almost none of them requires nodal histopathology. So none of them thinks nodal histopathology is mandatory to decide whether to treat or not the dog. This is because histopathology requires a surgical excision of the lymph node or a biopsy of the lymph node, so this is an invasive sampling procedure, and many dogs are old, have a systemic disease, and sedation or anesthesia may not be suitable for affected dogs. This is a paper from Laura Marconato where the comparison between canine and human lymphoma was discussed, and she proposed this flow chart when approaching to dogs with peripheral lymphadenopathy. The first step, of course, as we have already told, is cytology. Cytology of enlarged lymph node can confirm lymphoma, as in the picture I showed you before, or not confirm lymphoma, being either negative or not diagnostic. In case of the confirmation of the lymphoma, a large panel of tests should be performed in order to stage the disease and to characterize it, including CBC, biochemistry, bone marrow aspirate, flow cytometric immunophenotyping with or without histopathology, abdominal ultrasound with or without fine needle biopsy of spleen and liver, and thoracic radiographs. And based on the results of this whole panel of tests, the clinician or the oncologist can decide whether to treat or not, and in case of treating, how to treat the dogs. But what about negative or not diagnostic cytology? In this case, any other cause of peripheral generalized lymphadenopathy should be considered and should be excluded based on specific tests such as serology and PCR for infectious disease. If no cause for reactive lymphadenopathy, systemic lymphadenopathy is detected, then histopathology and PCR for clonality are recommended and should be performed on a whole lymph node. In this way, lymphoma can be confirmed. And again, we have to go back to the whole panel of tests to stage the disease and characterize and take decisions about treatment. Today, in this talk, we will talk about flow cytometry and about PCR for clonality. Flow cytometry is an advanced diagnostic technique which allows an assessment of different parameters on single cells in a suspension. It requires a liquid sample, which can be blood, can be bone marrow, but can also be an aspirate of any tissue where cells are resuspended in a liquid medium. In the cytometer, so in the instrument, the cells are moved by a water solution, a saline solution, so that each cell goes in a lattice chamber one by one. The cells are separated and pass one by one in the lattice chamber. Here they are hit by a laser light, and on the opposite side, the laser light creates a shadow on the detector. The diameter of the shadow is proportional to the size of the cell. So small cells give small shadow, larger cells give larger shadow with larger diameter. The detector captures this shadow, registers the diameter of the shadow, and gives a numerical parameter which is called forward scatter and is an index of the cell size. Meanwhile, a fraction of the incident light from the laser light is refracted all around the cell, and a second detector, which is set at 90 degrees from the lattice chamber, captures the intensity of the light, which is scattered at 90 degrees, and the intensity of this light is proportional to the cell complexity, which in turn is proportional to the nucleus complexity, the nucleus shape. This second parameter is called size scatter, SSC. So with this passing through the lecture chamber, we have an idea of the cell size and the cell complexity or the nuclear shape of each cell in our sample. Cells can also be pre-treated with antibodies before passing in the lecture chamber. In this case, what happens if the antibodies recognize specifically an antigen of interest, and on the other side is linked to a fluorochrome. The fluorochrome is hit by a laser light and emits light in a different wavelength. So, if the antigen is present on the surface of the cell, the antibody binds and the light will hit the fluorochrome, and the light in a different wavelength will be emitted and captured by specific detectors. If the antigen is not present on the cell surface, the antibody will not bind to the cell and it will be washed away during sample processing, so we will not have fluorescent light. What is important with flow cytometry is that we can use different antibodies, multiple antibodies on the same cell in the same tube. So we can assess the expression of different antigens on the same cell in a single experiment. We just have to care we use antibodies conjugated with different fluorochromes so that they will emit light at different wavelengths, and we will be able to detect whether the fluorescence is due to the presence of bluish or light bluish antibodies in our example. In this way, using a large panel of antibodies, we can define the antigenic pattern of each cell, so we can understand which molecules are expressed on the cell surface, and the antigenic pattern of the cells in healthy condition is specific for the cell lineage and the maturation activation status of the cells. In this picture, you see the wide number of different maturation status of hematopoietic cells. This is taken from human medicine, of course, but it is the same for dogs and for any other animal. And each of these cells is characterized by a different antigenic pattern and a different combination of surface antigens. So how can this help be interpreted by the operators? This is just an example of how flow cytometry results are shown to the operators. And they are the most commonly used is this one, the one up with this three-color combination, which is called dot plot, where every dot represents a cell passing in the lecture chamber. In this example, I put a sample from blood from an healthy dog, where red blood cells were analyzed during the processing of the sample. The black dots are debris or platelets, and you see three different cellular populations. Blue cells, which are low forward scatter, which we said is represents the cell size, and lower size scatter, which represents cellular complexity. So these are small cells with low complexity, and these are lymphocytes. The green dots are cells of intermediate size and intermediate complexity, and they are monocytes. And finally, the red dots, which are the most represented, have intermediate size and high complexity index, and these are granulocytes, neutrophils, eosinophils. The same sample is shown in different way in the other graphs. This is a list of the antibody available for flow cytometry in the dog, for diagnostic flow cytometry in the dog, and what is important is to understand that there are some molecules, these three ones, that are expressed on all leukocytes, so both myeloid and lymphoid cells at any stage of maturation should stain positive for these markers. Other antigen are expressed only on T cells. CD3 and CD5 are expressed on all T cells, whereas CD4 only on T helper cells and the CD8 only on T cytotoxic cells. 3 marks expressed only on B cells, 2 marks on myeloid cells, and these 2 markers which expression is normally restricted to the precursors, to the marrow, to the bone marrow precursors on the early cells in the maturation process. What about sample for flow cytometry? Flow cytometry can be, as I told you before, can be performed on liquid samples, so blood and bone marrow, of course, are just need to be set in a tube with an anticoagulant, and then they can be processed for flow cytometry, whereas lymph node aspirates need to be resuspended in a liquid medium. Also, other tissues from the organism can be sampled in this way. Liver, spleen, or extranodal lesions can be sampled with the problem that in case of suspected extranodal lymphomas, there is a little higher percentage of samples that will be not diagnostic because of poor cellularity, because extranodal lymphomas release a lower number of cells. What is the problem with flow cytometry? The problem with flow cytometry is that cells have to be alive, so the sample must be delivered to the laboratory within 24 hours for sampling. If you use a culture medium, otherwise you can make the aspiration from the tissue, from the affected tissue, and set in saline solution, but in this case it should be delivered to the lab within really few hours for sampling. Otherwise cells will die, and the antigen pathway can be changed, or can be conformational changes in the proteins, and they will not more be binded from the antibodies, so the results will be no more accurate. How can we do a diagnosis of lymphoma via flow cytometry? It is quite easy in the majority of cases where a dominant lymphoid population is found, having specific and monomorphic morphological and phenotypic features. In the first case I present here, you can see the population of small-sized cells with low complexity, which are small lymphocytes, small mature lymphocytes, residual lymphocytes in the lymph node. This is a lymph node aspirate, okay? And this other population of cells being larger in size than the normal residual lymphocytes and having a higher complexity index. In this second graph, the same sample is shown always on the forward scatter, so on cell size, and on staining of CD21, which we saw is a B-cell lymphoma. And you see that here, in this case, most of the cells, almost all the cells, are large in size and staining positive for CD21. So this is a large B-cell lymphoma, which is the most common subtype in dog. In this second example, the cells are small sizes or medium sizes, so it is more difficult to discriminate between the two populations based on morphological properties, but almost all of them staying positive for CD3, which we said is a T-cell marker. So in this case, we can diagnose it as small cell T-cell lymphoma. Another opportunity to make a diagnosis of lymphoma via flow cytometry is the detection of phenotypic aberrancies. What is this? We saw that each cell has a proper phenotypic pattern based on the lineage of origin and the maturation stage. But during neoplasia, during neoplastic development, something can happen, and the cells can change the antigen pattern they show. In particular, they can lose the expression of markers that should be expressed on that cell, or they can gain the expression of markers of different lineages. Or again, in case of T cells, they can express contemporarily both CD4 and CD8, or be negative for both CD4 and CD8. Here is an example of a lymph node aspirate with a dog with lymphoma with multiple phenotypic aberrancies, and you see that almost all cells stain positive for CD5, so they are T cells, T lymphoid cells, but they stain negative for CD45, which we said is a pan-leukocyte marker and should stain positive on lymphoid cells. The same dog was double positive for CD4 and CD8, which should have mutual expression on healthy lymphoid cells. And also these cells, which are T cells, stained positive for CD21, which is a B-cell marker. So this dog has a minimum of 3 phenotypic aberrancies, and the detection of phenotypic aberrancy is considered conclusive for neoplasia. This is a study I published some years ago, and we wonder about that subgroup of dogs where cytology is not conclusive for lymphoma, and they can have a small cell lymphoma or an hyperplasia, reactive nodal hyperplasia. How can flow cytometry be of aid in such cases? And we selected this peculiar cytological appearance where cells have this unipolar clear cytoplasm, which is called the small clear cell appearance by cytology. We found 26 cases in our database and retrospectively investigated the phenotype of these cases, and we found that almost all of them but one stand negative for CD45, which is a panleukocyte marker and should be positive in healthy condition. In the same way, most of these cases stand positive for CD21, which is a B-cell marker, but actually all of them were T-cell lymphoma because they were positive for 1, 2, or 3, or 4 T-cell markers, either CD3, CD5, CD4, CD8. Also, most of them were double negative for CD4 and CD8, or double positive for CD4, CD8, or had discordant expression of the pan-T-cell marker. They were negative for CD3 and positive for CD5, and this should not happen in healthy conditions. So, of course, flow cytometry can be of interest in this case and can confirm the diagnosis of lymphoma thanks to the presence of these phenotypic aberrancies. After this study, many other studies have been published on this topic, and in particular, the American group proved that CD45 negative lymphomas in flow cytometry have an histopathological diagnosis of T-zone lymphoma. So taken all together, our results and the results from the American group and many other results, many other research groups all over the world have brought to the establishment of this clinical condition, which is called small clear cell T-zone lymphoma or T-zone disease, which also has a unique clinical presentation, with the dog having generalized with lymphadenopathy, but usually the submandibular lymph nodes are more affected, and quite commonly also lingual lesions are present. The dog have this peculiar phenotype with cells being negative for CD45 but positive for the T-cell marker CD5, and what is also peculiar of this lymphomacyte type is that blood is always infiltrated, also with high percentage of infiltration, whereas bone marrow usually is not infiltrated, and this can be assessed via flow cytometry thanks to this peculiar phenotype. The dogs have, the tumor has an indolent disease follow-up in dogs, and dogs have long survival even in the absence of chemotherapy. So making an accurate diagnosis of this subtype of lymphoma is crucial, since it is not mandatory to treat these dogs unless they are symptomatic or any other clinical issue requires treatment. But the T-zone lymphoma by itself does not need to be treated. And a wait-and-see approach can be used in these cases. Phenotypic aberrancies are also quite common on extranodal lymphomas, and in particular in extranodal T-cell lymphomas, we found that about 80% of the cases showed any phenotypic aberrancies. I told you before that extranodal lymphomas more commonly than nodal lymphomas have poor cellularity, so the diagnostic yield of these samples is lower than nodal lymphoma, but when they have a sufficient cellularity and the quality of the sample is sufficient to be processed for flow cytometry, it is easy to find phenotypic aberrancies, and the presence of phenotypic aberrancy allows a more accurate staging of the disease via flow cytometry. Flow cytometry is also suitable for a better characterization of the canine lymphoma. Indeed, the proliferative activity can be assessed by the assessment of the percentage of Ki67 positive cells, and a cutoff of 12.2% has been determined to discriminate between high-grade and low-grade lymphoma. This is really important from a clinical point of view, since high-grade lymphoma have a more aggressive clinical course and need to be treated, whereas low-grade lymphoma can be not treated or treated with a less intensive chemotherapy protocol. Of course, proliferative activity can also be assessed via histopathology with mitotic count or mitotic index. Flow cytometry, as I mentioned before, can also be used to stage the disease. And in this paper, we validated the strategy to quantify blood and marrow infiltration in dogs with large B-cell lymphoma. Once you get on the lymph node, aspirate the morphological and the phenotypic picture of the neoplastic cells, you can easily detect them in the peripheral blood or bone marrow samples. This is the peripheral blood from a sample from a dog with a large B-cell lymphoma, and here cells are shown based on cell size and CD21 positive. So we know that neoplastic cells in the lymph node, it is a large B-cell lymphoma, so neoplastic cells in the lymph node are large sized and CD21 positive, and we can get the percentage of such cells in the bone marrow and peripheral blood. This is important since it has, again, a prognostic value, but these data have to be interpreted in the light of histopathological assessment of the lymphoma of that dog. Indeed, for dogs with diffuse large B-cell lymphoma, dogs having bone marrow infiltration assessed via flow cytometry higher than 3% have shorter time to progression and shorter lymphoma-specific survival compared to dogs with lower bone marrow infiltration. On the contrary, when an histopathological diagnosis of nodal marginal zone lymphoma is made, the cutoff change. The strategy to quantify the infiltration via flow cytometry is exactly the same, but the interpretation of the result is different. In this case, indeed, dogs with peripheral blood infiltration higher than 30% tend to progress more quickly, have a shortened time to progression than dogs with lower peripheral blood infiltration. Instead, talking about bone marrow lymphoma, we had a 3% cutoff for diffuse large B-cell lymphoma, but we have a double cutoff of 1% and 20% for dogs with marginal zone lymphoma, with dogs having more than 20% infiltration in the bone marrow having a shorter survival time, and dogs with less than 1% bone marrow infiltration having longer survival time. Dogs with bone marrow infiltration between 1 and 20 are this line, and they are in a gray zone where prognosis and survival cannot be predicted. This is the same case we told before, with cells being CD5 positive, CD45 negative, and also in this case they are easily identifiable, and the percentage can be assessed in the peripheral blood sample of affected dog. As I told you before, peripheral blood is always infiltrated, and this does not bear a worse prognosis in these dogs. Finally, flow cytometry can also be used to assess flow cytometry-specific prognostic factors, such as the level of expression of class 2 major histocompatibility complex with dogs with a lower expression having poorer survival, and also the percentage of proliferating cells. I told you before the percentage of Ki67 positive cells help us to discriminate between aggressive and indolent lymphomas, but among dogs with high-grade B-cell lymphoma, it also can be used to stratify among 3 different prognostic groups based on the cutoff of 20 and 40% of positive cells. What about PCR? PCR for antigen receptor allows the identification of clonal proliferation in the lymphoid population. So the technical principles are the same of the PCR. There are multiple cycles of denaturation, annihilation, and extension of a segment of DNA based on the use of specific primers, and then the PCR product can be run on an electrophoretic gel, on a capillary gel electrophoresis, and the PCR product will be separated or will stop their course in the gel based on their molecular weight. But how can this be useful to diagnose lymphoma in a dog? We have to start from the beginning and remember that the lymphoid cells have a B cell receptor or a T cell receptor based on the lineage of the cell. And in the normal evolution, in the normal maturation of the lymphoid cells, the genome sequence encoding for the variable region of the receptors, B cell or T cell receptor, encounters a number of random insertion or deletion of nucleotides or small segments of the DNA segment, and finally this will result in a different DNA sequence of the variable region of the immunoglobulin or the T cell receptor, so that each lymphoid cell in the organism has a different gene sequence for this segment, and the different gene sequence have different molecular weights. This is aimed in the organism to have different mRNA and different peptide chains so that each lymphoid cell can recognize a different antigen, and the organism is protected against a great number of antigens. But in case of neoplastic transformation, only one single clone of lymphoid cells proliferates, and so all lymphoid cells that proliferate have exactly the same genome, and this segment of DNA has exactly the same molecular weight. So when we do perform PCR, we amplify this segment of the genome of the DNA, and we can have this picture in case of reactive lymphoid population or resting lymphoid population, where different segments or different molecular weights are amplified, and we have a smear of products on our gel. On the contrary, if there is a neoplastic evolution and a clonal proliferation, we just have one single band of a single molecular weight on the electrophoresis gel. So this is positive for lymphoma, this is PAR positive results, and these are negative because there is a smear in the band on the gel. And the same is true for capillary electrophoresis. PAR was introduced in veterinary medicine almost 20 years ago to diagnose canine lymphoma, and from then on protocols have been updated, and many different clinical settings where to use PAR have been described, and the set of primers have been changed over time and enlarged. But what is important with PAR is that it can be performed on any type of sample. It can be performed on lymph node aspirates, such as for cytology and flow cytometry. It can be performed on tissue biopsies. It can be performed even on storage samples, on formalin-fixed tissue biopsy, even on stained cytological smear. It is the only test that can be performed on archive samples, on the contrary with flow cytometry. So we have three different techniques to diagnose lymphoma in dogs. We have histopathology, we have flow cytometry, and we have PAR. I now will show you some pros and cons of these three techniques. Starting from sampling, histopathology requires a tissue biopsy or better a lymphadenectomy or the removal of a whole lymph node from the dog. This is, of course, the gold standard technique to diagnose and classify lymphoma, but it requires an invasive sampling, and sedation or anesthesia are mandatory to remove a lymph node from a dog. And this is not always possible with old dog with systemic illness. Flow cytometry needs a fine needle aspirate, so a minimally invasive sampling procedure can be performed on any tissue, even if different diagnostic yield have to be considered. But the limits of flow cytometry is that it requires high cellular samples with high cellularity and vital cells. So I told you samples have to be delivered within 24 hours to the lab. They have to be kept refrigerated but not to be frozen. Otherwise the cell will be no more suitable for cytometry immunophenotyping. Finally, PAR can be performed on any type of sample on any tissue, even on tissue that release only few neoplastic cells when aspirating. What about phenotyping, which is a major prognostic factor for canine lymphoma? Histopathology can determine the immunophenotype of the lymphoma, of course, but it requires immunohistochemistry. And this will take a longer time because you have to wait for the histopathological report, and then you ask for immunohistochemistry, and it takes some more days. And actually, you will have a final definition of the lymphoma subtype and the phenotype within some days or 1 week from the day you took the sample. Also, a limitation of histopathology is that only few antigens can be tested because many of the antibodies don't work on formalin fixed samples. Flow cytometry, of course, can be used to assess the phenotype of lymphoma, as I showed you before, an example of B-cell and T-cell lymphoma, and it also allows the discrimination of specific flow cytometric entities such as T-zone lymphoma. PAR can be used to get the phenotype, okay, yes it can, but this is not the best choice because B-cell lymphomas commonly have a B-cell receptor clonal arrangement, and T-cell lymphoma commonly have a T-cell receptor clonal arrangement, but it also cross-lineage rearrangement can happen, so a B-cell lymphoma can result clonal for both B and T-cell receptor, or B-cell lymphoma can be clonal for T-cell receptor and vice versa. So phenotype can be identified by PAR, but this is not the most accurate test to do this, and in my opinion you should prefer histopathology or flow cytometry and limit the PAR test to get the phenotype of the lymphoma only to those cases where histopathology and flow cytometry cannot be performed. Further characterization of the lesion of the lymphoma of that dog, yes, histopathology allows this. Pathologists can assess the tissue architecture, the cell morphology, the proliferative activity via mitotic count, and definitely this is the only test which can define the WHO subtype of the lymphoma. Flow cytometry can give a further characterization of the lymphoma subtype. Of course, we can get information about cell size, about proliferative activity on the neoplastic cells, and we told before there are some flow cytometry specific prognostic factors that can be assessed. Also, flow cytometry should always be performed in conjunction or after cytology, so a morphological assessment of the single cell has to be performed via cytology. PAR doesn't tell of any other characterization of the lymphoma. It just says the dog has or has not a lymphoma, but it doesn't give any further information. Can these techniques be used for staging? Histopathology cannot be used for staging unless tissue samples are taken from any organ in the organism, but this is quite invasive. Flow cytometry can be used for staging, particularly in peripheral blood and bone marrow sample are the most suitable for flow cytometry processing, but Any tissue with a simple aspirate can be examined via flow cytometry, and also before of the prognostic value of bone marrow infiltration, which depends on the histotype. So with flow cytometry, we can determine the level of infiltration of both blood and bone marrow, but then these results has to be interpreted after a definitive histopathological diagnosis has been made. Finally, PAR, halo staging, yes. You can perform PAR on any tissue aspirate, so there is no problem to detect whether tissues are infiltrated by neoplastic cells or not, but PAR doesn't allow to assess the degree of infiltrations. It is much more sensitive than flow cytometry in detecting infiltrating sample, but actually when we get a positive result, we don't know whether the sample has a low or minimal infiltration or is it mostly composed by neoplastic cells. In conclusion, I wanted to show you this study from our research group, which consider the usefulness of the three techniques, histopathology, flow cytometry, and PAR, on dogs that had a diffuse large B-cell lymphoma, had been treated with chemotherapy, obtained clinical complete remission, and after the end of the chemotherapy, we tested the lymph node with the three techniques. And you see here the results in this table. Okay, histopathology was almost unuseful, since almost all cases just had follicular atrophy, which is quite simple to be predicted from a clinical point of view, since all dogs were in complete remission. And only in 2 cases we have again a positive result from histopathology with neoplastic cells still surrounding the lymph nodes. With PAR and flow cytometry were performed on lymph node, peripheral blood, and bone marrow samples, both techniques on all matrices from all dogs. PAR was almost always positive, and the vast majority of the matrices from the old cases it was positive, whereas flow cytometry was only occasionally positive. This is due to the higher sensitivity of PAR, of course. And what we found with statistical analysis is that dogs with positive results from both PAR and flow cytometry had shorter time to relapse than dogs with negative PAR and negative flow cytometry result, or positive PAR, negative flow cytometry result. As you can see in this table, there was no case in which flow cytometry was positive and PAR was negative. Again, this is due to the higher sensitivity of PAR. But what is interesting is that there was only a few number of cases where PAR was negative, and these dogs were the ones that had the best prognosis, the most prolonged time to relapse. But actually what clinicians need is not to know which dog will do well, but which dog will not do well and will relapse within few days or weeks, because that dogs is like to need a more aggressive chemotherapeutic regimen or closer follow-up controls, because it will relapse early. And maybe PAR is not the best technique to select these dogs, since the vast majority of dogs are still PAR positive at MRD, at minimal residual disease control. So in this further study, we assessed the usefulness of flow cytometry to detect dogs which are likely to relapse in a short time after the end of chemotherapy. Again, dogs with large B-cell lymphoma, and the same approach in flow cytometry. Just as for staging, we looked for the percentage of cells large size and CD21 positive, so large sizes B cells in the lymph node aspirates after the end of the chemotherapy protocol. And what we found is that dogs with more than 0.5% of large B cells in that aspirate after the chemotherapy in dogs in complete remission is correlated to a shortened time to relapse. So dogs with more than 0.5% neoplastic cells will relapse within really a short time, and it is better to program closer follow-up controls for these dogs. On the contrary, flow cytometry assessment of residual disease on blood and bone marrow didn't show any significant influence on the time to relapse on these dogs. So among the 3 techniques that we tested to check minimal residual disease in dogs, histopathology does not give useful information. Usually you just find follicular atrophia or which is of no clinical interest. PAR and flow cytometry can be performed, and you gain different information from these 2 tests. PAR is more sensitive, so PAR negative results means really there is no virtually no residual neoplastic cell, and the dog will do well and will have a prolonged time to relapse, whereas dogs with flow cytometric positive results, which means more than 0.5% neoplastic cells in the lymph node aspirate, will have a short time to relapse and may benefit of a continuation of the chemotherapy protocol. Thank you for your attention.
So, first of all, I would like to thank you for inviting me to speak about the European Canine Lymphoma Network. The European Canine Lymphoma Network has been one of my creators of the last 10 years. And what is this network? This network is a community of people working on different aspects of canine lymphoma. And the network was born in June 2009 by a joint initiative of the University of Milan and the University of Vienna in Austria. And we started from realizing that in spite of the very similarities between canine lymphoma and human lymphoma, the consistency of the results in the study of canine lymphoma are not so strong as in human lymphoma, and this is mainly due to the lack of enough numbers of cases or the lack of standardization among different institutions. And so we started with this point, and we went on with the proposal of joining all the researchers that are interested or that are working on the study or the cure of the canine lymphoma in Europe. At the moment, we succeeded in our aim to collect most of the researchers working on this field, and at the current date, more than 27 different institutions all over Europe are registered. And we started with this idea in 2009, but the real creation of the network started in Lugano, in Switzerland, at the first meeting of the European Canine Lymphoma Network in June 22nd, 2013, where we have more than 120 attendants, and we have been invited to organize this workshop as a satellite workshop to the International Conference of Malignant Lymphoma, which is the most important meeting all over the world on human lymphoma. So we succeeded in getting together vets and biologists and medical doctors and all people that are interested in this interesting topic, which is canine lymphoma and the possible comparative and translational use of canine lymphoma. The aims of the creation of the network are quite ambitious, I think, and they started from an harmonization of the laboratory protocols, but also of the therapeutic protocols, as a potential prerequisite to the validation of some specific diagnostic tools that can be used for a research paper, for research projects. The editing of some consensus documents among different institutions that can harmonize also the approach to the disease, and the definition of some common research targets, also in terms of writing together some research projects to ask for grants and to try to put together all the people that are working on a single disease, in order also to increase our caseload, similarly to what already demonstrated in human medicine. And lastly, the establishing effective collaborations and some integrated prospective research projects among all the people that are interested in the issue of canine lymphoma, independently from their country of origin, independently from their skills, independently if they are coming from academia or if they are coming from private clinics, for instance. So, who was the target of the European Canine Lymphoma Network? Of course, we started identifying the vets that are working both in the academia or in the private vets working in the clinics, because many clinical oncologists, at least in Europe and in Italy, are working in private clinics. Our aim was to put all these people together around the table and to try to exchange experiences and to also to exchange cases. All these people were invited to participate to the network and the activity of the network, independently from their skills and their different fields of interest. So we have many pathologists, some clinical pathologists like I am, some medical oncologists or surgical oncologists, and of course we also have radiologists and people working with radiotherapy. And okay, this is the main target of our network, but the network is not intended to be just limited to the veterinary community, since we are very interested in involving into the network also biologists and medical doctors that are interested in the possible use of canine lymphoma as a comparative model of a spontaneous disease. I think that this can be a very interesting point, and it's not easy to involve people working on human lymphoma in the study of canine lymphoma too, but I think that now we have many evidences about the possible similarities and the possibility of the canine model to work for a rapid development of, for instance, some new drugs or new therapeutic approaches. So also pharma industries are potentially interested in the canine model, since if we consider that drug development with a clinical trial on human cases, on human lymphomas, probably take more than 20 years for registering a new drug. In contrast, in the dog, we can skip a great part of this research, a great part of of these trials, and so the use of the canine model can help also pharma industry to try to shorten the process of drug developing. And of course, we are also interested in involving all the people that are interested in education. So students in veterinary medicine or residents of different European colleges that are interested in the continuing education. This is a timeline of what we've done till now. We started with the presentation of the project, as I told you, in 2010 in the European Society of Veterinary Oncology meeting in Turin, but the real foundation of the network started in 2013 at the first meeting in Lugano, in Switzerland, and then all these all our activities is synchronized with this biannual appointment at in Lugano at the ICML meeting, where they invited us to organize our own meeting and our workshop on canine lymphoma in 2013, 2015, 2017, 2019, and we have been invited also to organize something similar the next year. And during the creation of the first phase of the activities of the network, we also were very much involved in the dissemination of this new network, and we participated to some presentation to a meeting organized in Nantes in France by INCA, and then we had a working meeting in the meeting of the European Society of Veterinary Clinical Pathology in Milan, and another one at the European Society of Veterinary Oncology in Vienna in 2014, and other meeting in conjunction with other European organization and societies. And regarding our activities, the first years of our foundation started with the creation of the platform, the informatic platform, and the informatic facility to support the network activities, and to create the panel of experts that can act to as a director of the process of all the processes of the network. And in terms of aims, one of the first aims that we started with was the creation of some consensus documents about some specific issues, and these consensus documents lead to some research papers that have been published on internationally recognized high impact journals. And after this phase, we slightly move towards the creation of some other initiatives that started from creating the background for developing some research projects. In terms of publications, we still have some interesting papers. As you can see, some papers published by the network about the creation and the aims of the network, and some other about consensus documents, such as this one on the reports of flow cytometry in canine hematopoietic neoplasm on cytometry, and this one on veterinary and comparative oncology, which was an overview and a review on the controversies in the diagnosis, staging, and follow-up of canine nodal lymphoma. We made a systematic review with a critical review of the last 15 years of published literature, in which we underlined that there are many discrepancies about what I've done in different institutions. And then we had also some research projects that were finalized in research papers, such as this one on breed-associated risk for developing canine lymphoma among different countries. And this proceeded, this interesting survey that has been published in the proceeding of the European Society of Veterinary Oncology in 2019 by a French group, in which a survey, the results of a survey on diagnostic imaging in the managing canine lymphoma has been conducted. Another important point was the dissemination of the activities of the network, and this was mainly mainly linked to development of some media, starting from a website. We had a website that represents our activities in the past, but we at the moment we had some problem with the old domain, so we started with a new domain. This girl is the person in charge of managing the new domain. Our new website will be online as soon, is still under construction. I wish to thank Sabine Hammer, who is the webmaster of this. She is a great scientist, but she also gave a part of her time to the activity of the network on this specific issue. And in contrast with the website, we have also a Facebook page, which is probably the most updated page in which we used to publish our initiatives. We currently have more than 900 followers from all over the world. I wish to invite you all to register to the Facebook page if you are interested to keep updated with our initiatives. We also use the Facebook page to update on all our network's activities and the meetings and the topic of the meetings, the invited people, and we use also to publish some relevant articles on canine lymphoma. We use to perform kind of journal club, and we wish to disseminate all the things that have been the new things that have been published on the topic. And we also use the Facebook page for advertising calls for collaboration in research programs, or for positions, or any other business related to the study and the cure of canine lymphoma. So I invite you all to join. The registration is free, so it's really easy to join to our community by clicking like in our Facebook page, thus remaining updated on our initiatives. We also started with a new media, an Instagram page, with the aim to expand our social activities also to the young colleagues. This process is still in process. this page is not working so much, but we are all looking for young people that are possibly interested to collaborate with this page. So if any of you is a very social people, very social person, and want to help us to organize and publish on this Instagram page, please contact me, and I will be happy to welcome you on board. How can you join to our community? I think that the most the easier way is probably to visit the Facebook page, which has this address, and click like, so you can remain updated with the network activities. We will plan to conduct a survey on all the participants to the network as soon, probably in the first month of next year, and you all will be requested to fill an appropriate form in the next month, with all your contacts, with all your skills, with all your caseloads, with all the things that you want to share with us, in order to update the community, since we started with a very little group of people participating, and now we are including a huger community all over the world. Of course, if you want, you can also contact us personally. These are the contact people. Myself, I'm the chair of the panel on diagnostic, since for internal organization, the network activities have been divided into two groups, a panel on diagnostic and another one on therapy, and I'm the chair of the panel on diagnostic. This is my email address. And the chair of the panel on therapy is Laura Marconato. So also Laura will be available to answer to your question on the possibility of joining to our initiatives and to our network. I have been asked to help for a possible establishment of a research network in India. Of course, all these initiatives are very welcome. And I don't know if I have the recipe for a correct way of organizing a network, an Indian network in this case, but I can give you some suggestions that that derive from my experience in managing the European Canine Lymphoma network. We started with the identification of all the participants. So the first phase is mainly focused on the dissemination of what we mean to do, what we wanted to do, and this is not an easy phase, because at the beginning people it's quite difficult to explain which is the aim of the network, and at least in Europe, we had some difficulties in putting all the people together around a single table, because in some cases we can have some competition, or people that are generally not interested in collaboration with other people from other countries. We have many discrepancies also in terms of quality of the research in different academia or in different countries. So the first part is really important, and you need to explain which is the real aim of the network, which is putting people together. Second, we need to identify the skills and the caseloads. This is mainly focused on identifying the people that can be involved in different aspects of the study of canine lymphoma, such as diagnosis, therapy, pathogenesis, comparative aspects, pharma industries, and so on. And this identification is a crucial crucial point in order to define the roles, the possible roles in the network, and in order to create an organizing committee. The organizing committee, one or more organizing committees, are necessary because we need to trust in the availability of people that want to give their time for free for these activities. So they have to believe in this project, and so it's crucial. A crucial point is to identify the correct people for creating these organizing committees. And then we need to define some short-term and mid-term aims that can be controlled, can be checked by giving some checkpoints, such as, for instance, we have the checkpoint of our biannual meeting in Lugano. What I learned from this experience, I learned that one important point is the continuing organization and participation to events, or to continuing education days, or also the continuing publication of information and research papers on the web page. So people have to be involved in every possible way. Another important point is the interaction with other groups, for instance, with the European Canine Lymphoma Network, or with the Veterinary Cancer Society, with international societies of pathologists, of clinical pathologists, of surgeons, or oncologists, and so on. And then another crucial point is the interaction with the human medicine. I think that a key point for the success of the research network is the possibility of convincing human doctors or people, biologists, for instance, that are working with human lymphoma to take part in the activity of the Canine Lymphoma Network, since this can give us a stronger vision, a stronger possibility, and a stronger visibility in the world. And then two other suggestions. The first one is be flexible and facilitate the background for creative interactions, any kind of interaction. Also using new media, social media. I'm not a young man, so for me it was quite difficult to approach to Facebook, to Instagram, but we have the possibility of involving young colleagues that are probably much more interested in using these media, and are really interested in participating with their skills. And then the second suggestion is be inclusive as much as you can, since each participant may be a source of help in the activities according to each one's skill. The younger colleagues may help in the social activities, the aged one can help with their experience, people coming from the academia can have some facility for organizing, for instance, meeting, or people coming from private vets have much access to case loads and so on. So each participant has something to share with all the other people. And I think that the success of a network is mainly based on the possibility of being as much inclusive as we can. Before leaving you, I would like to invite you all to attend to the 5th meeting of the European Canine Lymphoma Network. that this year, according to the COVID emergency, will be held in a webinar on the month of June 2021. Unfortunately, we won't be able to participate in presence to the invitation in Lugano of the ECML, but we will be there with a webinar open to all the people that are interested. The date and the platform are still to be defined, probably Microsoft Teams, but you can be updated by joining and keeping updated via Facebook page. You are all invited to attend. The registration will be probably free. And I will be happy to welcome you to our activities. And I wish to thank you for your attention, for your interest in the European Canine Lymphoma Network and in our activities. Thank you. I will be glad to answer to your question.
selected 7.5 linear probes. There is a reference marker here that will always guide us to locate the area where we want to take biopsy. Now what I located in the spleen, you can see the cattle-like cattle reticular pattern-like appearance of the spleen. Normally spleen are homogeneous structure, hypertrophic structures than liver. But here you can see the spotted appearance like a cattle reticulum. And when you want to take a fine aspiration biopsy, my finger, you imagine like a needle, the cursor that will present on the probe, it will guide you to take material. Just I am showing how to take a fine aspiration biopsy. So this is the case of spleen lymphoma. Now I want to know whether it is having all the mesenteric lymph node enlargement. We are going towards all the now I located the urinary bladder. Below the urinary bladder we can see one hypoepic section. That's why I have improved. Normally below the urinary bladder the hyperepic structure is the colon, and below that you can see the hypoepic section, that is the colonic lymph node. So colonic lymph node involvement is there. Choroidal lymph nodes are enlarged, and liver is having uniform echogenicity. Adjacent to the liver, the liver border to the organ is right on you can also see the inguinal lymph node enlargement, and now you want to see the kidney seems to be fine, no abnormality, but now we can see the mesenteric lymph node enlargement inside the abdominal cavity, and then there's the abdominal blood vessel. Adjacent to that, you can see the hypoetheric structures. These are mesenteric lymph node. Most of the studies shows, when the lymph node having enlarged structures, hypertrophic structures, and suppose having a lot of blood supply, that's normally indicating T-cell lymphoma. So they have taken the blood, and now we can see from the abdominal blood vessel. Now you can see a lot of blood supply going to the enlarged lymph node. So it shows now in the present image you can see the all mesenteric lymph node enlargement, and already you have seen the splenic lymph node, colonic lymph node enlargement. So it is a case of splenic and the mesenteric lymph node enlarged case, and it's also having all the enlarged peripheral lymph nodes. You can see the popliteal lymph node. We measure both the left side and right side popliteal lymph node. You can also see the axillary lymph node. Can you see the axillary lymph node enlargement? Similarly, you can also see the prescapular lymph node enlargement, and now we can also see the below the mandibular lymph node enlargement and pharyngeal lymph node enlargement. So, if it's one lymph node is enlarged, stage 1. If it's one side of the lymph node is enlarged, stage 2. If all the lymph nodes are enlarged, stage 3. This is having all lymph node enlargement peripherally. But when we do ultrasound, we found splenic lymphoma while doing ultrasound. That is stage 4. And involvement of bone marrow, that is stage 5. So it is a case of stage 4. Already they treated with a couple of days of chemotherapy. The owner didn't turn up for another subsequent treatment. And again, it's plant, animal doesn't eat. And we also find some amount of ascites in this case, this particular case. When we do with by using this aeroscan ultrasound machine, normally lymph node involvement, linear probe is playing an important role, and we have a curvilinear probe. This is actually for examining the liver. We can make use of it very clearly. This is frequency 3.55. This supports 7.54. This is a phase array transducer. This can be used for visualizing the heart. In this case also we examine the heart chambers. There is no pericardial effusion, and there is no middle wall regurgitation. There is no middle wall thickening. And we also checked any effusion inside the thoracic cavity. We couldn't appreciate any effusion inside the thoracic cavity. So it is a case of stage 4 lymphoma. Now we are planning for the chemotherapy.
We normally administer Sonoviv with the contrast agent. Now you can see the contrast agent going to the various parts of the organ, and also you can see the white flow. That is the Sonoviv contrast agents going into the lymph nodes. And if it is a malignant nature, it goes into the enlarged structure. It will clear quickly. But it's a benign, it takes more time. That's the way it will help to characterize. And also what we did know, we also use characterize the lymph node by measuring the length and width of the lymph node. If the length and width of the lymph node more than 0.5, it's having a malignant nature. Mostly the T-cell lymphoma, they have a pattern like that. Majority of the cases in our study also we observed the T-cell lymphoma. All of them is having a more than 0.5 ratio. Stefano, Comazzi?
Yeah?
Yeah, you are there? Okay. So actually, there are 395 questions from 1,600 participants. So I will read out some. Valeria, you are also there?
Yeah.
Yeah. I'll read out some of the few questions. And, there are questions like, mild, moderate, and severe type. How the lymphoma pattern, stage 1, stage 2, stage 3, 4, and 5, like that. So the ordinary cases will reply over the mail. The guest speakers, they can answer to the queries through mail. Some of the interesting questions I'll ask them, and they can answer to this. One answer, Pasuluddin. He asked, how do you identify lymphoma by cytology?
Ok, come poi il linfoma in circolazione. So the question is for Valeria, I think. It's correct, huh?
Yes. The lymphoma, how do you identify with the cytological characteristic?
The cytological characteristic of lymphoma. Okay, Valeria.
Okay, can you hear me? Okay. Now, cytology is the first step in the diagnosis of lymphoma, and when you have a lymphoma, you have a clonal proliferation, so all cells have similar appearance on cytological smear. And as I showed you before, was the typical morphology of diffuse large B-cell lymphoma, where almost cells were large-sized and where they were pleomorphic because they had a different number of nuclei, but actually none of them was a mature lymphocyte. When you have a reactive nodal hyperplasia, instead you have an heterogeneous population of lymphoid cells, but most of them are small mature lymphocytes, just as the one you find in peripheral blood smears. So they are small-sized with clumped chromatin and scant cytoplasm. Or you can also have a mixed medium size or large size large cells, but they just represent a minority of the cells in the reactive hyperplasia. You can also have plasma cells and macrophages, whereas in lymphoma samples you have the prevalent population being monomorphic, and usually in the dog it is medium or large sized and not small mature lymphocyte. There are only a minority of the cases having small cell lymphoma, and this cannot be distinguished from reactive hyperplasia via cytology. So the most important feature in cytology is the presence of a monomorphic population to diagnose, to suspect or diagnose a lymphoma.
Yeah, thank you, Valeria. The next question is, what are the predisposing factors for canine lymphoma? Predisposing factors.
Well, there are lots of predisposing factors. Some of them have been listed at the beginning of the webinar. Of course, breed predisposition, with large breeds being more predisposed. And there are also predisposition of the breeds towards specific lymphoma subtypes, with Rottweilers, as an example, being more predisposed, boxers being more predisposed to develop T-cell lymphoma, so more aggressive from a clinical point of view. Interestingly, this breed predisposition vary all over the world, and the recent literature shows that, as an example, golden retriever are predisposed to develop T-zone lymphoma in America, but not in Europe. European golden retrievers do not develop T-zone lymphoma. So maybe this is not only a question of breed, but really of genetic line and genetic predisposition. And then also environmental factors can have a role. As you said at the beginning, the dog shares the living habits of the humans, and when humans have environmental factors that predispose to development of some types of cancer, including lymphoma. Also, the dogs has this predisposition. These environmental factors predisposing to the development of cancer and lymphoma.
Yeah, thanks, Valeria. The next question is, ideal chemotherapy of canine lymphoma.
I think this answer will be given in the webinar tomorrow from a clinician. According to the published literature, there are many different chemotherapeutic regimens, and most commonly with aggressive lymphoma or high-grade lymphomas. What is important is to use a multi-agent chemotherapy protocol. For the differences among the protocols, you should ask the clinician.
See, the best type of chemotherapy protocol is there are several drugs, single agent, they can use prednisolone. The longevity when you use prednisolone only 45 days. You can also use doxorubicin at the rate of 30 milligram per meter square or 1 mg per kg body weight. The longevity when you use doxorubicin 6 months the survival period. The another important chemotherapy protocol, Madison Wisconsin University protocol. If you use that, the longevity can be up to 2 years. It again depends upon the severity of the lymphoma. See, the stage 5, so if it is a T-cell lymphoma, the prognosis is poor. And that's the way, you need to keep the, in your mind. Then another question is, about the differential diagnosis of lymphoma. What are the differential you can think? See, when the animal is having enlarged lymph node, what are the other differential you think?
Okay, this depends on the clinical presentation of the lymphoma. For multicentric lymphoma, the main differential, at least here in Italy, is leishmaniasis or systemic parasitic diseases. Leishmaniasis is the most common one with generalized peripheral lymphadenopathy, whereas for extranodal or localized clinical presentation, you can have any other disease or any other neoplasm to be included in the differential.
Yes.
I have a question for you.
Yeah,
because this issue is particularly interesting, I think. Since leishmaniasis is probably the most important differential diagnosis in Italy or in the south of Europe. But what about your experience?
Yes,
because I think that you have many infectious diseases that can mimic lymphoma. So I'm really interested in your response.
I am about to tell, but Stephanie, you asked me exactly. See, we get maximum 1 in 4 dog in India. 1 in 4 dog, they are prone to get ehrlichiosis or Babesia zibzoni or canis or Anaplasma pilatis. This was a study conducted by American Parasitology Board in one of the state. So, majority of the hemoprotozoan disease, they have enlarged lymph nodes. That is one of the thing. Another thing, when the animal is having any chronic infections, that's also they have an enlarged lymph nodes, inflammation or any infestation. And what we observed, even recently, there was a 45 days old puppy having enlarged peripheral node treated by an experienced veterinarian in a nearby area. The puppy belonged to an experienced pediatrician. He himself an oncologist. Then he brought the dog to us. We examined, the peripheral blood smear was negative. We did FNAB, no lymphoblastic cells. The PCR we conducted, PAR conducted, no sign of lymphoma or B or T cell. Even immunohistochemistry we can know. But with the PCR, what we conducted in the blood sample, we identified that is a case of Babesia zibzoni. Then we put him on with triple therapy called doxycycline, clenda, and metronidazole. Believe it or not, the entire family become, mentally depressed because the pet became a family member now. The treating veterinarian now became a family veterinarian, a family doctor because the pet became a family member. So they attached very much. We put him on with the triple therapy. The dog is doing fine now. They brought it here 6 months before, and till date the dog is doing fine. All the peripheral lymph nodes and all subsided. And he was so happy and he was thankful to our institution. These are all quite interesting case history which we attended in the past.
So I'm very interested in this point. I think that I'm interested in your case.
Yes.
In your cases,
Thank you
we
very much.
have to exchange our experience about this.
Thank you. Thanks a lot. Another two more questions. With that, we'll wind up. The rest of thing, we'll answer the guest speaker. They can answer through the mail, or I can also answer to the participant questions. Then another thing. Actually, these are all things they will answer to. There is another oncologist tomorrow. They will answer to all the treatment aspect. They are asked about the recovery rate of canine lymphoma. If it is a B cell, how it recover, a T cell, the recovery rate.
So I think that both Valeria and me are not probably the right people to answer to this question. So we are clinical pathologists, but just to give you an idea, we have to consider that the lymphoma in the dog is still an incurable disease in most of the cases. But we describe this. There's less than 10%, to be honest, of long survival in these cases, dogs survive more than 2 to 3 years. That, according to our experience, since in most of the cases these are older dogs, we can consider that these dogs have been cured. And interestingly, most of these dogs, almost all these dogs with long survival, has some characteristics. They are all large dogs, and they have a B lymphoma, diffuse large B-cell lymphoma with centroblastic appearance. They have generally, they are negative in the peripheral blood and in the bone marrow. They are not in the substage B, so they are in substage A. That means that they do not have clinical signs, and they have not been pre-treated with the corticosteroids therapy. So if the animals has this characteristic, they have a bit more possibility of being a long survival and to survive more than 1 year. But generally speaking, I think that we can consider that in most of the cases we can consider that the lymphoma, the median lymphoma survival for B-cell lymphoma is about 1 year, and for T-cell lymphoma is about 3 months. At least for high-grade lymphomas. If we include the T-zone lymphoma, which is indolent generally, we can also have many cases with more than 2 to 3 years of survival. This is a very interesting point, since we need to, as a clinical pathologist, we are mainly interested in identification of the prognostic factor in order to better to tailor the therapy and to predict the prognosis. Then I think that your next guest in the next days will be able to give you some more information about the prognosis and the survival. That's all, I think, for what it is in my scale.
Yeah, thanks, Stephanie. The last questions I will answer to this, if you permit me. Can I proceed?
Yeah.
The question is, what are the various types of lymphoma? One of my colleague, Vinu David from Kerala, I think. There are different types. We know there are cutaneous lymphoma. It will mimic like a non-healing skin ulcers, and it will be like a pyoderma, or you can see the erythematous lesions. They don't respond to routine therapy. And another important thing is most of the cutaneous lymphoma which we have seen, they end up with a bad prognosis. Alimentary tract lymphoma, they have a vomiting and diarrhea. When you do an ultrasound, you can see a mucosal thickening. Central nervous system lymphoma, they have ataxia. The most important thing is ocular lymphoma. Many dogs which we have seen in the past, the 75% of the dog, up to 5 dogs, they lost the vision because the delayed referral and, is coming with a vague sign. They say owner is telling blindness. The blindness, you will have a retinal detachment, corneal opacity. There are a multi number of disease. But when we did PCR and PAR-SA, we confirmed the case of T-cell lymphoma. Then we put him on with the Madison, Wisconsin University protocol. Then multicentric lymphoma, you will have a enlarged lymph node all over the body. So that they call it as multicentric lymphoma. And see, we have a hepatic lymphoma, we have a splenic lymphoma, we have a mesenteric lymphoma, we have a colonic lymphoma. See, wherever the organ, no, there are, pericardial lymphoma. Even the 6-month-old puppy, they recorded pericardial lymphoma. It is involved all the parts of the organ in the body. So yearly referral, we'll have a better prognosis. Late referral, we'll have a bad prognosis. And with this, I finish my conversation. And I thank Stephanie and Valeria for their wonderful contribution. And I request Stefano, Comazzi and Valeria, they should coordinate with us for the future collaborative work. And see, we are the only people in the world maximum number of dog populations. So our study, naturally it will help. Stephanie, you asked the case load. In the case load in the world, we are the number one. Recently, I have been to Wasava conference in Canada. There is a professor, genetic professor, who asked me the first questions, who is from India? I raised my hand. He told me that my country is the only country in the world having maximum amount of canine population. So the study naturally to reflect the all other parameters. So we need your cooperation, guidance, and with that we can do under One Health concept, we do something for the canine population and also human populations. Thank you very much. And
of course, thank you. Very, very, very appreciate it. Thank you very much for hosting us.
Yeah, I leave the mic to my colleague, friend, classmate, Dr. Tirumurugan. You will give a vote of thanks.
It's my pleasure and privilege to propose the vote of thanks during this TANUVAS Global Veterinary Oncology Webinar Series 2020, and today's topic being Canine Lymphoma Update. We take this special occasion to thank our Honorable Vice Chancellor, Dr. Sri Balachandran, who also happens to be our overall coordinator for the DBT-TANUVAS Canine Research Center and Networks program funded by the Department of Animal Biotechnology, for his presence, inaugurating the webinar, and also being a constant supporter for all our activities. Our special thanks to Dr. S. Balasubramaniam, the Director of Clinics and also the Program Coordinator of the Project Monitoring Unit of the DBT-TANUVAS Canine Research Center and Networks program, for his meticulous planning and mentoring us at every stage of this event. We take this opportunity to thank our Registrar TANUVAS for providing us the necessary administrative sanction, and the Dean Madras Veterinary College for his support and all the necessary permission to use this conference facility. Our special thanks and deep sense of appreciation to our speakers, Dr. Valeria and Dr. Comazzi Stefano, for their wonderful lecture and also sharing their expertise. Our special thanks to the Department of Biotechnology, Government of India, for the funding to the Canine Research Center Networks, under which this webinar has been organized. A special mention and thanks to the Vice President, Mr. Karnanidhi, and Dr. Santosh Shinde, from our information technology partner, Mrs. Alembic, for supporting us in smooth conduct of the entire program. We would like to thank Dr. M. Chandrasekhar for introducing speakers and also coordinating the question and answer sessions. Our special thanks to Dr. Vijay Kumar for his excellent coordination, and Dr. Vimal, the technical coordinator, for supporting us to maintain the network connectivity and the webinar platform during this webinar. So it's also time to thank the Professor Knight Department of Extension Education for providing us this conference facility and also for the photographic coverage. I would like to take this opportunity to place on record our hearty thanks to all the staff and faculty of Canine Research Center Network, the Project Monitoring Unit, and other fellow colleagues for the perfect logistic support extended to all of us. To conclude once again, I would like to thank the speakers and all the participants from all over the globe to being with us this evening and making this webinar a grand success. Thank you to one and all.